Next speaker, Dr. Alexander Donat, please. Optimizing periorbital rejuvenation with volume restoration.
Well, thanks so much. Thank you, Alwyn, for the honor of presenting to you all today, and thank you to the committee as well. I want to congratulate them also on a fantastic meeting. So I'm from the U.S., where I do quite a bit of periorbital rejuvenation. I'm in my 17th year now, so it's a lot of fun and it's gratifying for both the patient and physician. These are my disclosures. When we look at youthful periorbital tissues, we notice that they're dominated, regardless of the height and position of the brow and shape of the brow, that they're dominated by highlights, and these are created by convexities. And with age, we begin to lose these convexities and become hollows, so they become concavities, which create shadows. Also, in addition to soft tissue loss, we have, of course, bony loss, which leads to a radial expansion of the orbit. And if we don't recognize this, then this can lead to us chasing the ideal position of the brow for surgical brow lifts up the forehead, as I believe happened in this patient, where earlier she had a much lower position and less hollow periorbit. So what might be a useful reference point to prevent us from going so high up the forehead? Well, if we look at the palpebral fissure height without ptosis, then frequently that height above the upper lid margin, I think, is a useful upper limit for the position of the head and tail of the brow. So what do we do to recreate the highlights from the shadows? We can use synthetic fillers, as we did in this patient with a particular HA filler that was minimally hydrophilic. This one was Restylane, and got a nice improvement of the lower periorbital area with her perhaps almost a surgical appearance. And this was in a paper that we published showing the long-term retention of synthetic filler in this area, about an 85% retention at 14 months. That was just the average follow-up. If we followed them up longer, we would certainly see it last longer. I've seen it myself, 7 and 8 years respectively for the 2 times I've had it done. So moving on to fat transfer then. Fat has certain advantages over fillers in that it's natural, it's durable, there's no chance of a Tyndall effect, which we can see with superficial placement of HA fillers, of course. There's a possible stem cell effect, it's easily combined with other procedures, and it's inexpensive to incorporate in your practice. Disadvantages are the increased downtime. Patients have to be willing to accept a second week, and the imperfect predictability, so patients have to be willing to accept the possibility of a second treatment. Usually it's less than 10%, and we wait a full year for that. It's more challenging in patients who are thin, where it's harder to find the fat and keep it. Older patients and those with unstable body weight, patients have to be reminded that if they gain weight, their face will too, where the fat was transferred to. And also because it's durable, you don't want to overfill and create irregularities. So we're very careful to prevent irregularities, which is the most common concern I think the patients have, but when done carefully, it's extremely rare. And of course, as with synthetic fillers, we have to be cautious about intravascular injection. Our technique is basically one of gentle handling and careful insertion. We use mainly the 1.2 millimeter cannula for this. The 0.9 we mainly use just for the superficial infraorbital rim. Multiple passes and small amounts per pass. So we typically do 5 passes per 0.1 cc on average in the superficial infraorbital rim, and then 3 passes elsewhere. And that helps us prevent irregularities. You say a rolling stone gathers no moss, so a moving cannula gathers no lumps. So we also inject, of course, only on withdrawal. We do infiltrate PRP afterwards to try to decrease bruising. I'm not convinced there's an improved retention with that. And we're now restricting lidocaine to try to improve retention and recommending patients not ice excessively, as I think that can have a deleterious effect. So just a couple points about the technique of injection. As opposed to synthetic fillers with fat, we can use a single inferior access point and don't want to use a lateral canthal access point or lateral access point, because that can create a bit of a sausage roll deformity, which I think is because of the orbicularis retaining ligament. But regardless, we're protecting the globe with our non-dominant hand and palpating the infraorbital rim so that we're gliding just above that. For the supraorbital rim, conversely, we can address that from the lateral aspect and approach much of it from that lateral access point and blend it into the temple and forehead. And then the medial half to 2/3 we can also access from about the mid-pupillary line just above the brow. And so a range of volumes that we've used for the range of amounts of atrophy that we might see in our practice. Lastly, I thought this patient was instructive because she did her procedures in 2 phases. She did lower bleph and fat transfer and got a nice improvement, I thought, with that, both 3/4 and profile view, where we had a reduction of the lower lid pseudoherniation and an improvement of the midface convexity. And then she had a deep plane lift, more harmonious appearance, and the added benefit of the lift is fairly subtle. So I think at least in my hands, the primary benefit in the midface is still through fat transfer. So in summary, volume loss certainly occurs in the periorbital region, both superiorly and inferiorly. I'd encourage those who haven't already tried to do so to address the superior periorbital area as well. Addressing it is powerful and gratifying for both the patient and physician, but we have to consider the existing contours and any adjunctive procedures we're planning. Thank you.